back over the lectures, you can just fast forward if I start just going off on something that's not actually really important. Because the first things I'm going to touch on are the first thing I'm going to touch on is the syllabus and the schedule, because the schedule can look kind of hairy-carry. So I like to just pull it up. So we're going to look at the syllabus first, and we're going to look at how this class is graded. Okay, so it's a 4 credit class, but only 2 of the credits are for a letter grade. So if you're the kind of person that is really concerned with whether or not you get an A or a B, the only parts of this course that will have a letter grade put into it is the class that's on Tuesdays. So that's our lecture content. And then that's where the exams live, like just our regular multiple choice exams. So anything that happens on a Tuesday is a letter grade format. Um, whether or not you get an 82 on an exam or a 92 or 100 or whatever, all of that's collected that way. In the lab, so whether or not you have lab on Monday or Wednesday, basically everything in lab is based on proficiencies. So we practice a skill, and then you have to take a proficiency. And it's a graded proficiency because you have to pass at 75. But once you pass it, once you make that mark, it's just either pass or fail. So I collect all of that graded information separately from what I collect on Tuesdays. So basically what goes into your grade book or on your transcript is pass fail for the lab and then a letter grade for the lecture. But we kind of lump them both together, and then I just sort it out separately on my end. So you could fail a proficiency and have to retake it. But if you pass at, 78 or whatever, it's just the same as it looks the same on paper as if you pass at 100. Of course, the higher your skill set is and the better you do, the more confident that you'll be as you move forward through clinic. So you always want to try to do a higher grade, but it's not going to show up on a transcript. Okay, so we have these 4 lab sections, A, B, C, D. Everybody should hopefully know what lab section they're in. You just have to worry about that. There are several little wonky things here and there that I want to bring your attention to. But for the most part, all you have to know is we meet Tuesday mornings, and if you're lab A, we meet at this time, but in the clinic. So next Monday, for example, we don't have lab because of the accreditation for dental therapy. So we're not going to meet at all on Monday, but then the Wednesday group, we're going to meet in the clinic. So we're going to, instead of meeting in here, you'll go through the clinic doors and you'll go off to the left. So whoever is in a C or a D lab group will meet over there by the radiology units. And that'll be the typical thing. When it's your lab time, if you're from 3:30 to 5:30, you'll just come right in at that time, and you can be a few minutes early. I'd rather prefer that than you being late because it's a really short lab time. You have 1 hour roughly with Dexter, and then we have an hour of other activities. And so it goes by really, really fast. So I'd prefer you pop in 2, 3, 5 minutes early as opposed to late. Yeah.
Just to clarify, today, is it till 5:30 or 3:30?
So today I'm just going to get through some material. So I don't have a specific time on it because I just want to get through a chunk of material, and then the same with Wednesday. So actually, when we had a faculty meeting just a minute ago, and there's not going to be EHR on on this coming Wednesday. And so I'm going to start. So write this in big, bold, beautiful letters. And I have to remind myself. So we're going to start class instead of starting at 2 o'clock next Wednesday or this coming Wednesday, but not next Wednesday, like the day after tomorrow. We're going to meet in here as soon as you guys get out of Sarmiento's class and you have a bathroom break and get a drink. we're just gonna come right into here. And I have a student appeals meeting between 12 and noon. So I'm gonna have to get as much done for an hour and then we'll have to take a break and then we'll meet back here again to finish up. And hopefully my meeting is less than those 2 hours and then we can come back together. But that was a change that literally just happened over lunch. She asked if I could move our class up to start at 11. And it ultimately that's better for you guys, right? Because it'll ultimately get you guys out sooner. So yeah, and you could by that time you're gonna be like, please get me out of here. So this coming Wednesday we'll meet in here at 11. So anyway, so that's how, generally speaking, that's how the course will go. And we'll look at the schedule together here in a minute. The syllabus is all very standard. It has code of competencies and graduate competencies. It has protocols, all that are on everybody else's accessibility and accommodation services. If you have an accommodation, please come and see me and just talk to me about how you see that, what you need when we're doing our exams, if you do time and a half, or if you need material sooner. I got a letter, but I always like meeting with the students. So if you have accommodations, come and see me. And this is just all standard from the same. So what you really probably care about is assignments. So this is a mix of both the class on Tuesday and the lab. And some of these things are proficiencies and some of them are exams. But pretty much everything on this, actually everything right here is all part of the point system. So everything that's listed here, the final grade will be based on 1 through 6, and then take evaluation instruments. The evaluation instruments will have the following points. Those are all the assignments actually that will be reflected in a letter grade. So there's quite a few quizzes, but they are all take home. So tomorrow morning when we meet for our first lecture, at the end of class, I'll give you a quiz and it's take home. You can certainly work on it with a peer. I would recommend though that you really do take it by yourself and then check your answers with someone if you want to. I mean, there's no reason you shouldn't get 100% on the quiz since it's take home, but I don't mind if you hand it to me and you've like scratched out an answer and put in another one because you're like, oh, I realized it was wrong and I changed it before I handed it in. I'm fine with that, but test your knowledge, like use it to actually test your knowledge, use it like a quiz and then fix your answers. So yeah, there's no reason that you shouldn't get full points, but I would encourage you to use it like a quiz. But it's a way to throw you guys some like easier points to get. Carries and perio interpretation is a multiple choice exam, comes later in the semester. There's 3 other full multiple choice exams. A landmark exam is an exam, it's all pictures and you're going to type in the answer. So it's fill in the blank. The comprehensive exam is at the end, it's during finals week. And then there's completion of lab activities that are proficiency. So like taking the bite wing proficiencies, FMX proficiencies, a timed proficiency, setting up an XCP proficiency, mounting proficiency. So there's all these proficiencies, and those are all in lab. And so those are pass fail. And this just breaks it down again. These are all the different lab proficiencies. The very last thing you do in this class, the last 2 weeks, you bring in a live patient. A lot of people bring in friends and family, but they have to need a full mouth series. So if you want to bring in your husband, but like 2 years ago, he had an FMX, he can't sit for your patient. You have to find someone that like literally needs an FMX. And so I like to just say that up front because sometimes people think they know exactly who they'll bring in, but then they end up not needing a full mouth series of x-rays. So an FMX is a full mouth series, 18 films, and you'll learn all about that by the time it's time to do it. But I like to just put it out there and then we'll talk a lot more about it. Okay, so that's the syllabus. Any questions so far?
Question.
Yes. There's two questions. Go ahead.
It was about the schedule. I was kind of confused what you were saying. I thought we were meeting for the EHR on Wednesday.
Normally you absolutely meet for EHR, but for whatever, and I apologize. I don't know why there's not EHR this Wednesday, but it sounds to me as though it got canceled. And so the director asked me to move my class up just for the day after tomorrow, just that one Wednesday. So I'm not entirely sure what happened there, but just to kind of give you guys less of a huge break, because you'd probably be doing nothing between 11 and 2. And so she's trying to consolidate it for you guys. So it's only just that Wednesday. Did you have a question back here?
Oh, I was asking that when our patient comes in, like our friend, are they required to pay or is that?
That is a good question, and I do think that they pay, and I think it's $50. We do take insurance, so you can also find out the insurance up at the front. Okay, specific instructional objectives. So these are all the objectives for all the PowerPoints. It's a great way to study. I just put it there. Questions oftentimes are coming from objectives. So if you ever, what does she want me to know in this lesson? What's the important part to know in this lesson? One tool you can use is the specific instructional objectives. Okay, class and lab at a glance. This is the beast. It's probably not so much of a beast as much as Sarmanto's. I'm sure hers is beastier, but this is the mini beast. This is the little beast. Okay, so I try to spell out everything. So like all students today, 1:30 to 5:30. We're not going to be here till 5:30, but 1:30 to 5:30, and then tomorrow morning we're going to be in this classroom from 8 to 9:50. Wednesday, scratch that. It'll be 11. There'll be a break. And then I think what I'm going to do, if you guys can just stay tuned on your email, check your email, or if you've set up a group Discord or something like that, the minute I get out of my meeting, I'll be like, meet me back here, and I'll give you time to, if you're like went off to get lunch or get coffee, but I'm like done with my meeting, head back to class, and then we can finish up. So that way we can hopefully be as like efficient with our time so that you guys can get out of here as soon as I can possibly let you out on Wednesday. But that's so we'll start at 11 and then we'll have that break and then we'll see how much more we need. Monday, there's no lab. For anybody who's a normal Monday lab person. Tuesday, we're going to meet for our Tuesday lecture across the street. So you just walk right across the Max tracks into that building, and we're going to be in room 250. So we're going to be there for my class and then also for McGee's class. I'm not going to go through this whole schedule because I don't really have to, but I do want to give you a feel for what to look for. So the normal Wednesday group is going to be next, and then of course we don't have another lab because of Labor Day, and then we're going to do a repeat of that same lab, but it's going to be the normal Monday group. So the first 3 weeks are very wonky. So I know it's a lot to be like, routine is better. Routine helps us feel like predictable, and we know what we're doing, and we know where we're going. And that is just not happening for the first 3 weeks. It's like, now we're here, now we're there, now we're here. So email me, but I did try to put it all on here. So if you read through it, kind of line by line, it's there. But just like with everything, it makes perfect sense in my head. It might not make perfect sense in yours. So I do not fault you for that. So just ask me and I'll try to clarify as best as I can. But hopefully nothing should change. And then after that, we should have oh my gosh. After that, we should have several weeks of just this good routine where if you're a Monday A person, this is what we're doing. Tuesday morning lecture. Wednesday, it's a repeat of Monday. It's just a different groups. And so it should be this nice repetitive schedule. And then we do have a few more changes as we get down the schedule. A few funky things. The funkiest thing that we got is on week shoot, week 11, let me see. I think, week 11, interpreting carries 30 minutes to expose. No, that's a timed Dexter. Week 12, is it week 12? Where is the landmark exam. Okay. So the landmark exam is classically an exam that you take on Tuesdays in class. But because we have this funky beginning to the semester because of the dental therapy accreditation, I lost a little bit of places to put things. And so I ended up putting the landmark exam, and I actually think really honestly, you guys probably you don't know how I did it before, so you have nothing to compare it to. But one thing that students always kind of complained about was that the Monday lab group would pick my brain about the landmark exam. They'd be like, what do we have to study for and what's it going to look like and blah, 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 blah. And so on Monday lab, they get like this sort of little leg up on, and then Tuesday we'd have class and we're talking about some other content. We're not talking about anatomy. And then, or then Tuesday we have the exam and then Wednesday they're back to doing whatever the Wednesday group would be doing. So they always felt like Monday got like a little sneak, not a sneak peek, but they got a little extra time. So what I did was I'm gonna create a schedule that basically you're gonna go in and you'll pick a time slot. So it'll probably throw you off of your rhythm. It's like instead of Monday at 1:30, this week you're gonna be Monday at 3, or this week you're gonna be Wednesday at 2 or Wednesday at 3 or whatever it is. And so the week 12 is gonna be a little bit different. So just tuck that far away in your brain, but just we'll revisit it because we're going to do this landmark exam all together in class on Wednesday. So there's a few little tricky things, but for the most part, we get into a nice rhythm with our radiology labs and lectures. Okay, I think that's all the detail I really need to go in. Just that's a very important document. I think the takeaway is just make sure you look at it a lot, you're comfortable with it. This document here has your actual group, whatever group that you're in. So we'll pull that up. I don't print stuff off anymore because so often people they want an electronic copy. They don't want it printed. But if you ever want me to print this stuff for you, just ask me. I'm more than happy to do it. So these are the groups. You're either in A, B, C, or D. And then these are the kind of the funky little outliers. So I put it in I kind of pull them all out and I'm like, these are the times when there's an exception. So you can look at it a different way as well. Do you guys have any questions on the schedule? Uh-huh.
For tomorrow, we meet here this
Mhm.
on the Tuesday, next Tuesday, we're gonna meet on target to the.
Yes, yes. Thank you for clarifying that. Tomorrow, 8 a.m. here. Next Tuesday, just that one time, we're going to be in a different building because of the accreditation. That's Jack just threw a little, craziness into our lives. But when it's over, it'll be nice because then a lot of people will be less stressed. Okay. Another thing I wanted to let you know is on Moodle, do you see this link says sign up for extra help here? One of my office hours is Tuesdays 12 to 1. Yeah, Tuesdays 12 to 1. I can also go in the labs. The seniors are in the clinic Tuesday afternoon. Obviously, they're inpatient care. But if anybody has something going on between 12 and 1 and they want some remediation or we need to schedule a remediation, there might be other times a little bit later Tuesday afternoon, like around 2 o'clock or 2:30 after the seniors have taken their x-rays on their patients. But you guys can always go in here and sign up for extra time. If you feel like you just didn't get enough practice, especially those of you who've never done anything with radiographs before or dentistry, I am thrilled to help you just play with Dexter a little bit more, talk about some concepts, just troubleshoot one thing. We can do it for an hour. We can do it for 20 minutes. We can, whatever you need. So this is just there for you guys to sign up as needed. And the link is always there under the general section in the Moodle page. Yeah.
Do we have to request edit access?
Oh, is it not letting you?
No.
Okay, I'll switch that. I'll make it so anyone can edit. Yeah, thank you. Okay, so yeah. Yeah. Mhm.
So in my lab?
So next Monday, no lab. So yeah, it's seriously hard for me to keep it straight in my head. So next Monday, no lab for radiology. I can't speak for anybody else, but I'm pretty sure that there's nothing because everyone, well, you guys might have a lecture, you might have something, you might be having a lecture in the opposite building on Monday. I don't know. Don't ask me about anyone else's class. But yes, radiology has no lab on Monday. But we do have lecture on Tuesday.
And the lecture will be held in the.
Other building, yeah, on the room 250, so the second floor. Okay, so there are a lot of resources also. Some of them are very old and they're not my favorite, but I haven't deleted them just because it's like, I'll just leave them there. But like the Zoom link for the course, if you're ever sick, just click into here, and I always turn on the Zoom link and I record lectures. Sign up for radiology. Instructional videos, like I said, some of those are really old and I'm like, what was I doing? But I mean, they're not horrible. If they're still, showing you what you need to do, but they're just old and I don't know. But I kept them in there. There's other resources that you can use. I will refer you back to those folders if I'm like, the resources that you need for X, Y, and Z is in this folder in Moodle, but you can paw through there and just see the things that are available, but there's nothing specific that you have to do with that right now. Lab exercise interactive practice. This link, where's the link? Where is the link? Here it is. That link is going to be very, very useful when we're practicing. Even if you're one of those people that you like to do things visually, there's a little interactive game that lets you assemble an XCP. You just kind of click it together like with your mouse or whatever. There's also mounting. There's about 10 different full mouth series of x-rays, and you mount the individual x-rays in the place that it's supposed to go. So it's just a nice little interactive activity. And then there's other ones that have to do with taking panos and the positioning. So it's there and people forget it's there. And when we get to those topics, as we move through the topics, I might say, go back to the lab exercise link in Moodle and practice, because it will help you with a little bit better understanding, especially if this is all brand new. Okay, so I think since we got through that, then what we're going to do now, if there are not any questions, is we're going to go into the first PowerPoint here, which is Intro to Radiology Lab. So I'm going to open this up. Okay. So or I shouldn't say next Wednesday, when we meet back in here, because we haven't gone into the actual operatories for you guys to see all the things. I'm gonna grab some pictures and show you a few things just that way. Just it's hard to get all 32 into that space. And it's only me, and so I don't want to rotate you. So I'll try and bring in some specifics, but there are a few pictures here in this PowerPoint that hopefully you can kind of see what I'm talking about. But these are the objectives for this. We're going to talk about Dexter. Dexter is just a training head. You guys who've taken radiology before, you've probably used Dexter. It's a real life skull. It's a real bone with real teeth, but they're glued in. So there's these real elements, but then there's these kind of, like a fake rubber tongue, and there's some foam inside of his head. And so there's some kind of funky things, but it's just a simulation. It's a training tool. And so we're going to talk about how to properly care for him. We want to understand properly caring for all the equipment in the radiology space. understanding the PPE or the personal protective equipment that you're going to have to wear and use, the disposable supplies. And then we're going to talk a little bit about expectations. Yeah.
Do you recommend we get a binder for this class?
I think there's a lot of material, just like everything. I think it's a good idea to have like a binder when you're talking about a class that has like protocols and different things. Like when we take bite wings, you're going to want to know all the things about bite wings when we take the different elements of the FMX. So I think that's a very good way of going about it. Some people know that that's how they study best or stay organized. Some people might start out thinking they're going to do it and then they never put anything in the binder. So, but I think that's a good suggestion. It's a good way to stay organized. Okay. So there's Dexter, lovely guy. And so Dexter is tricky because his teeth are not perfect. His teeth sometimes they're rotated, and so it can be hard to open a contact, which is one of the criteria that we're trying to do when we take a nice X-ray. The palate can be narrow, the tongue can be stiff. The bite, he doesn't bite well, and so the XEP goes wonk, and it like kind of goes wonky. So there's things about Dexter that's not ideal, but the nice things about Dexter is he doesn't gag. He doesn't complain, and you can at least get a sense of how to place a sensor. Your biggest learning curve will happen next semester when you start taking x-rays on humans. You will get to place on each other though, and you really want to give each other feedback. You will figure out right away, like, oh my gosh, it is kind of gaggy, or it is hard to place. The tongue and the saliva and the cheeks, they're all in, and you'll just get a feel for it when you place on each other and give each other good feedback about it. But really, there's only so much you can learn on Dexter, and until you taking x-rays on people with all of their variations, the simulation only goes so far, but that's what we have to use, right? So that's what we do. So dental x-ray teaching and training replica. So Dexters are really expensive, and they do get damaged. Their teeth can crack, and hopefully nobody will drop him on his head. But if something happens, we do sometimes have to put them out for repair, and it's really expensive. It's usually closer to $4,000 to repair a Dexter. I don't know if you can see these the little metal handles up at the top. They come straight out of his head. Sometimes the springs and the movement, the mechanical movement, breaks down. We have to send them out to like get him to close again and things like that. And it is really expensive. So just when you're handling Dexter, I'll give you guys a picture of it for Wednesday. Actually, it's in one of the videos that you watch. Anyways, I'll make sure you know where he is. He's in the cupboard in the x-ray units in a little foam bed. And so when you go to pull him out and put him on the chair, you just want to be aware of the weight of Dexter's head and just have a good secure hold so he doesn't tumble out of your arms. We want to try to not pull and rip at the rubber and the foam and the fake tongue because some of them can be kind of in the way. And when you're trying to do a skill that you've been taught and you're frustrated because it doesn't seem like it's working for you, the last thing we usually care about is the equipment. We're like, and we want to get it done, but you want to think about taking a breath and stepping back and asking for help as opposed to kind of like roughhousing with Dexter because they do get a lot of wear and tear, and they are expensive and hard. We have to wait a long time. These are hard to come by because they're like skulls and teeth. So if one goes out of commission, we have to wait a long time to get another one. So we want to be careful we don't want to snap the teeth together. We want to just set him up carefully on the chair so that we just minimize hopefully any damage. So there are these black hooks. This is just what ours looks like. He's in a nice little bed underneath the cupboard where the computer is. That we have 4 X-ray operatories, and there's a computer and a cupboard, and he's in the cupboard in his little foam bed. And then you're gonna put these hooks over the back of the chair that's in the X-ray unit. You just slide them over the back, and then there's a strap that you secure his head. Really easy to set up. Once you do it once, it's not a problem. You just want to make sure you do it with care. So there's a foam pad that lays over him. It's like a little, I call it his blanket, and that goes underneath these black hooks. His head is heavy, so you just want to be careful that he doesn't fall out of your arms. Turning on the X-ray machine. So this picture was not meant for this, but do you notice hiding over here in the corner? This is the only picture I could find that had that switch in it. So that's why I grabbed this picture. There's 4 operatories. There's 2 here and 2 on that side. Am I thinking about that right? 2 here and 2 here. And when you go up to the entrance, just outside the entrance, there is this 3-drawer cubby. And next to every single one of those 3-drawer cubbies is that on and off switch. That's how we turn the machine on. You can turn the machine on inside the room, but we never do. We just turn it on and off from outside. So if you ever come to your room and all the lights are off and the control panel is dark, just flip the switch on the outside of the room. That's sometimes people will switch it on the inside, and then we're like, why isn't the outside one working? It's, so we try to keep them both on and only turn it on and off from the outside. Okay, this is the control panel. This is on the outside of the room. And this, you just want to get to know this because there's some tricky things about it. For one, the big button in the middle that looks like what are those things that we use when we're at the picnic? What is that? Like a bullhorn or whatever? It looks like a bullhorn. Some of the rooms, when you push the button, it beeps very quickly. Other ones, it beeps really low and long and slow. And if you don't hold the button the entire time, it just errors. So there's a few kind of tricky little things about it. So this button in the middle is where the exposure button happens. It's what you actually push to take an X-ray. And then we're also going to adjust based on these teeth. So who can tell me potentially what this tooth represents? Maxillary or mandibular? Maxillary molar. So for those of you who haven't worked in the dental field and you're like, what's maxilla? Why are you talking those terms already? We're just gonna, in this class, I have to start using them. So it's almost like you'll hear the words and then you'll take another class where you'll really study the words. So I have to just start talking with those words. And then in dental anatomy and in Sarmiento's class, then you usually get the full lesson on mesial distal, maxillary mandibular, anterior posterior. You'll start getting those words, but we have to start somewhere, right? So these buttons here are basically going to give you kind of a little cheat sheet on where you go. So if you're taking a maxillary molar image, you're going to push this button. Clearly, that would be the opposite, the mandibular molar shot, whether it's a PA, usually it would just be a PA. This one is the confusing one because people are always like, is that a canine or a premolar? And I'm like, it doesn't matter. Who knows? But I think it's more like, I call it a premolar, but honestly, it looks like it could be both. So again, in the premolar region, maxillary mandibular, anterior, so your central and lateral incisors, either maxillary or mandibular. This one over here, we don't use it. It's a similar exposure time. It changes the number down here. It's an exposure time. So it's how long are you radiating the person, whether it's 0.125 seconds or 0.6 or whatever it is, or 0.06 or whatever, then it changes the number to. And then who can guess what this one is? Bite wings. Yep. So that's for all bite wings. So just if you're doing either a premolar bite wing or a molar bite wing, you're going to push that one. So you just want to get to know it. If this number, the exposure time, if it starts blinking because you didn't push the exposure button long enough, all you really have to do is push these up and down arrows, kind of just push them a couple times and it sort of resets. Worst case scenario, just turn the whole thing off and start over again. If you're like, it's not working, nothing's clearing, then just turn it down, turn it off and let it reboot again. Okay. So a couple do's and don'ts. So we're not going to have to use PPE when we're working on Dexter, when we're in the lab. But the one thing that we do, want to do is use a sleeve. So if you can see in this picture, there's a plastic sleeve on the sensor. So we do want to use a plastic sleeve, but we don't want to hang it up in the holster. So, and the reason is because even though we know we're working on Dexter, we know Dexter has no saliva. In general, we just don't do anything where we're not sure if something is clean or dirty. Is that clean? Is that dirty? I don't know. So there's just a few things that if we're going to use the sensor, it's going to be laid across the counter we use a tray and we just leave it on the tray. And then when you're all done, take off the sleeve, wipe it down, and then put it back in the holster. So we just don't want to see a wrapped sensor in the holster because we just don't know if it has saliva. Now, is there saliva in, does the holster need to be wiped down? We aren't sure. So that's why we want to keep it just on the tray. Speaking about the sensors, again, another sort of, relatively expensive piece of equipment. There's not much to it. It's just a chip inside of a plastic casing, but it's like, 10 grand or whatever. So the biggest thing that can go wrong is, if it gets dropped and it lands just so on its corner, it could disrupt the internal mechanisms. So that could, maybe thankfully, knock on wood, that has not happened, but I suppose that would make it so it doesn't take pictures. We might have to, trade it in. They tend to be under warranty, but we still don't want anything to happen. Hopefully we can avoid it. So, when you're using it, this cord that comes out, you just want to try to keep it nice and straight. You don't want to bend it. Don't want to have the Dexter bite on it, or when you're using it in patient care, have patients bite on it. So we try to keep it out of the way as much as we can. I have seen them get dropped before, but thankfully nothing has ever happened. Another, just how to handle the equipment. The X-ray unit has these articulating joints. So this joint, you open it way up and then you can bring the whole tube head far away from the wall. And one thing you're going to notice is when you're taking an X-ray, when you bring this tube head to Dexter and you're trying to line it up in the target and it kind of floats, kind of starts floating away and you're like, it's not staying where I want it to. A lot of times it's because the articulating arm is closed. So the more you open it up like this, the more stable it's going to be. But if it lives like this, the joint gets weak. So a lot of times that floating where we can't get it to like sync up to right where we need it to be is because they've just lived too long in this open position. So after you're done, when you're all done in your room and you're putting everything away, you just want to close that arm up tight against the wall. Okay, so this is the little 3-drawer supply drawers that we have outside of each room. Basically you can reach in with clean hands, if there's a little cotton plier, you can use that. But as long as your hands are washed or, you've used alcohol, wipe, whatever, you can go in and you can grab the stuff. Just make sure your hands are clean. If you're wearing gloves, that's more of the no-no, because again, are they clean gloves? Were you just using them on a patient? Likely you probably just put the gloves on and now you're reaching for something. But in general, we're assuming your hands are clean if you're reaching into those drawers. So you just want to make sure. And then, okay, so that's that. You can just apply that to everything. Are their gloves dirty? I don't know. So pretty much anything that you're setting up, you will set up with clean hands. So you don't don gloves until you're ready to actually treat. Okay, aprons are optional. So here's a patient back when we wore a lead apron. Same patient doesn't need to have a lead apron. They are available. You do not need to bring it up to every patient. When you see patients, just go forward taking x-rays without a lead apron unless they ask you. So we have a sign that says, you know, if you want a lead apron, you can have one. We have them, but we're just moving through without using it. And we just that yeah, last year was the first year we did that. So it's still kind of new to us, but we're like, okay, nobody's using them in practice. Who works somewhere that uses a lead apron still? Yeah, it's definitely still done. And that's why we were like, do we, don't we, do we, don't we? But we just felt we were getting more and more feedback where people weren't using them as much. It's an absolute patient comfort thing. If the patients have been in a practice for a long time and all of a sudden you take away their lead apron, they're like, they're trying to kill me. I mean, they just don't get it. And I'd probably be the same way. Oh, you needed it for like 100 years and now you don't need it. Yeah, right. So, you know, people have like questions about it. But it's just one of those things where all we have to do, we can explain to them, and we go over this a little bit later, but in the biological safety unit, which is in a couple weeks, but we can explain to them the reasoning behind it. I won't go into it now because we're all too exhausted for that. Okay, so some expectations. After I do this, we'll take a break. So practice, practice, practice. There's like I said, there's limited amount of practice on Dexter. Some of you have had more practice than others. Do not compare yourself to your neighbor who's been taking x-rays. It's fine. And even if you've been taking x-rays and you're like, I just never felt like super confident, this is the place to work out all of those kinks. We're all going to get to the same place eventually. Some people get there faster in one skill set. Some people get faster to for another skill set, you know, somewhere else. So we all have to move at our own pace. So when somebody is like, I'm done, and they're just sitting there like this, and you're like, oh, I don't even know how to do it yet. Don't compare yourself. We're all going to get there. And you can practice more and you can set up times too if you want to more time out of class to practice. Try different things. We're going to try tabs without the rings. We're going to try the snap array, which is a different thing that's rarely used, but we still need to try it. And then the XEPs are the common. It's pretty much what everyone uses. That's the holders that most everyone use. Ask for help when you're struggling. If you take a picture and it comes out badly, and you take it again and it comes out badly, what should you do the third time? Ask for help. Don't keep making the same mistake over and over again because it's usually something really easy that we can easily like just correct. It's like, oh, you're doing this and you should do that, or, you know, whatever. Critique every film. The only way you're going to get better, the only way you're going to know what you did wrong, or the only way you're going to know if some criteria is missing is if you critique yourself. So we critique a lot, a lot, a lot. And you'll get sick to death of hearing it, but we actually critique all the way through the whole 2 years. Once you start taking pictures on patients and patient care, we critique those as well, because those like matter more really because they're humans as opposed to Dexter. Evaluate your partner's films when you place on each other. So when we have time in lab for peer partner placement, really give each other some good feedback and don't rush through it, especially if you partner up with another dental assistant and you both are like, we kind of know how to do this, all right. Don't rush through it. Like, do it and critique each other. Because maybe you paired up with someone who thinks they're hot snot, but they actually didn't do it very nicely. And so you can give them some feedback. So you really do want to take advantage of all these learning opportunities. Do not continue taking bad films without asking for help. That kind of is the same as at the top. If you've taken a radiology course before, just be careful about the kind of advice you give. Every year we have wonderful tips from dental assistants who've been doing it for a long time. Really good, solid tips. But really think about what you're saying and how you're saying it, because you could be telling them to do a shortcut that they're going to be tested on. And if you tell them like, oh, I don't have to worry about that, and then they don't do it, and we don't, and we're like, why aren't you doing this? We've been telling you to do this, and you're going to have a proficiency. You might be setting them up for failure. So just be careful about how you deliver advice. I'm not saying don't, because it's actually can be very nice to have people in there that have experience, but just be careful about telling them to not do something that they maybe have to do just because it's part of our curriculum, if that makes sense. Infection control. So just to briefly go through the infection control, almost all of the semester, we don't have to worry about it because it says clean hands, obviously that's important. And then it says Clorox wipes. That was more like COVID. We were like wiping down Dexter, like COVID, wipe everything down. We don't do it really so much anymore, but it is important because the last group on Mondays and Wednesdays, we do have to wipe down the room for the seniors. So that group those two groups get a lot of experience in room turnover for radiology. And so I try to stick it in there for the earlier Monday and Wednesday groups sometime during the semester so that you at least get to see it. But this is basically the rundown. This infection control, this is the rundown of how you're going to place it, all the barriers and everything. And it's not going to make a lot of sense to you right this minute because you're not looking at what I'm referring to. So like, a headrest cover is kind of self-explanatory, but plastic wrap over the keyboard, you're like, what the heck does that mean? We literally have a huge roll of saran wrap and you pull it out, about this much, and then you wrap the wireless keyboard with saran wrap or plastic wrap. So that's what that is. But I'll print this out for my Monday, Wednesday groups that are toward the end, and then we'll also have a few times when we talk about it a little bit more for those earlier labs. But with Dexter, the only thing you really want is to make sure that when you're grabbing supplies, because they are patient care supplies that we use, so you want to make sure your hands are clean. Okay, I think this is almost the last slide. PPE, for patient care, we use all the same PPE. We throw away anything dirty, just the same infection control that you will learn if you haven't already started talking about it for Sarmiento's. You're gonna wipe down the rooms with gloves, mask, eye protective, utility gloves. The dirty XEPs and the trays go to sterile. And then the chairs, the black chairs that are in the radiology rooms, those just get wiped down with soapy water. We don't use the Cavicide because it breaks them. They're just not the same material that can handle it, like the leather of the dental chairs. And then after you're all done with your wipe down, then you take off all your PPE and wash your hands. Okay. Does anyone feel like that? It's been lovely, but can I scream now? Because we're not done. We still have more to talk about, but we will take a break. So let's take a good stretching break. It's 2:30. Let's come back. Let's do 15 minutes. And then we'll come back for one more PowerPoint, and then we'll call it a day. Okay. Okay, so tomorrow we talk about physics of radiology. So tomorrow, and that is usually something that wasn't hit as heavy in dental assisting radiology classes, is the physics part of it is not usually talked about as in depth and is not tested as heavily. So that's usually something that people are like, ugh, the clinical part, they're like, oh yes, this is all, I'm comfortable, I get it, I'm familiar. But the physics part of it is tested far heavier. So tomorrow's lecture starts getting into that aspect of it. And that's usually a little more like new content, or you touched on it, but maybe not as in depth. And correct me if I'm wrong too. If your course was very similar, I would actually love to know. So these are just some objectives. We're talking terminology, little brief history. We're going to talk some more about equipment and the different types of radiographs, different types of images. What teeth should we be seeing on films? What are we looking for? We'll talk a little bit about critiquing, but I think I will revisit it again on Wednesday, and then really we go in depth more like in the weeks to come for critiquing. And then we'll define some terms, radiopaque, radiolucent, and then we'll talk a little bit about what you're seeing visually on an X-ray, the shades of gray, why some things are white, some things are black, the shades of gray in between, and so why that happens. And there's a whole lecture that goes more in depth into all of that. So it's just kind of an overview for this PowerPoint. So some terminology. So what is radiation? So we have kind of three terms that sound similar: radiation, X-radiation, and X-ray. It all sounds similar, but it's a little different. So radiation is sort of a packet of energy. It's carried either, they say that it like travels in a wave, but it's also like a particle. So it's like a particle that can also be observed in a wave form. So we don't go, I'm not a physicist, so I tell you as much as I can sort of comprehend. So that's where we kind of land. But radiation is basically like a form of energy. It's a packet of energy. X radiation is is a type of radiation that is produced when a high energy, where are we? A high speed electron sort of smashes into a particular kind of metal and releases an X-ray, or it releases heat, it releases an X-ray photon. So it's a particular kind of radiation that happens when we have this reaction that we'll talk more about tomorrow. The X-ray, so when you think of like the X-ray, you think of like the whole beam. So now we got a whole bunch of these particles that were developed from this particular reaction. So now we have an actual beam of energy that comes out of the tube head, goes through the patient's face and hits the sensor, and it creates an image because of that interaction. So that's your X-ray beam. The dental radiograph, it's a photographic image produced on a receptor. We don't even really talk about traditional films anymore. I took it out of the curriculum. They say they're not testing it on the national board. So basically we talk about digital radiography. Traditional films, we have some, I kind of pull it out in lab. We open them up, you can kind of see some of the things that, you know, people used to have to deal with, but almost nobody. I mean, you may find some elderly dentist in some rural area that refused to upgrade to digital, and that could be a thing. But everything you'd need to learn, you could be trained on the spot, and for the most part, so someone call me out. Am I saying it wrong? Has anybody used traditional films in their career in the last 2 years, 5 years, 10 years? Yes. So it's very rare. It's very, very, very rare. It's not to say it isn't out there, but it's incredibly rare. Okay, so we're mostly going to focus on digital. Okay, so dental radiology. So I have embedded, this is like, let's see how this goes kind of thing. I have embedded all these little interactive bits just to see how it goes. So radiographs are a necessary component of comprehensive care. And if you use that QR code, it should get us to a word cloud. And that will give people an opportunity. Hold on, I have to publish it first. I always want to do these like interactive things, but they take longer. And it's like, now I have to wait. Okay, hold on. I'll find it and I'll publish it in just a second. Okay. Is it this one? Are you guys already doing it? I thought I had to present it, but it's already working. Okay. Well, I'm glad that it's working. Okay, so what are dental radiographs? Okay, I even wrote the word wrong. Why are dental radiographs important? Not what. The sentence should be, what are dental radiographs important like for or useful for? Keeping record, diagnostic tool, visual aid for patients to help understand or classify disease, to help detect caries, periodontal disease, to illustrate changes, to diagnose. Those are all excellent. Documentation, visual, find hidden cavities or maybe very small cavities. Things are just starting to just barely. The one thing that we know is if we can see it on an x-ray, it's probably fairly good size, but sometimes we can start to see open margins or cavities that are forming underneath crowns and bridges or other fillings. So good. Those are all excellent. That's exactly what we're looking for. Let me get back to my Did I X out of it? Okay. Okay, so basically some things that you guys already said. So to detect lesions as well. So if there's something happening down at the root, down at the bottom of the tooth where the nerve comes out, there might be like an abscess, they might have a cyst, there could be something happening in the bone. We also want to be able to see things, says classify suspected disease or kind of determine, interpret periodontal disease and bone levels. If there's a foreign object, if something got stuck somewhere, sometimes if it's something that could actually be picked up, if it's metal or even sometimes some other materials might show up. Growth and development. If they are missing teeth and we're like, where are those teeth? Let's take an x-ray and then we can see where those teeth are. Maybe they're impacted, maybe they're sideways. So it gives us a visual aid that we absolutely cannot practice effectively without. So yes, of course, if it's a healthy person that has healthy home care, chances are they're not going to need x-rays maybe as often. But in general, it's the only way we're going to see interproximal in between their teeth. It's the only way we're going to see below the gum line. It's the only way we're going to see developmental changes and things like that. So we really have to have them, and we really can't do a thorough examination and give the patient all the information that they need if we don't have a set of films. And a lot of times people will bulk a little bit at having, and you've heard me use this term FMX, full mouth series. It's a set of 18 individual films. And a lot of times people will kind of just be like, oh, why do you have to take so many films? But what they don't understand is, yes, we could take a pano, and a pano is a film that's just one image of your whole mouth, and you can see some of the jaw, you can see some of the TMJ area sometimes, but the detail is not as good. So if we're really looking to see like the margins, the level of bone, the cavities and things like that, we really need a sharper image. And so that's why we take all these individual pictures so that the doctor has a good baseline. And that you would only do that every so often. And we'll talk more about frequency later. But a lot of times patients don't understand the reason for having that baseline information. We need that general understanding of what's going on in their mouth. So just for a basic history of radiology, they started discovering radiation or, different kinds of rays. There's cathode rays and different kinds of rays. And this scientist, Renkin, is how you pronounce his name. He was the first one to discover these X-rays. He was playing with a cathode ray, which is a different kind of radiation ray. And but he saw like a glow. And so he knew that something was coming off of this experiment that he was doing. And so he put his hand in between, he put some kind of a screen where this kind of reaction was happening, and he put his hand between it, and he could see on the screen like the bones of his hand. So he had his wife come in, and that big knobby thing on the finger is a ring. So something like, I can't remember what the textbook says. I think it said something like it took her holding her hand there for like 15 minutes or something under the under the radiation to get the picture. And long story short, both him and his wife died of cancer because they didn't realize over, the course of, I'm not sure how many years he experimented with the radiation, but they didn't realize it was harmful. You don't know what you don't know. And, but he did win the first Nobel Prize in physics in 1901 for his work in discovering that. But Coolidge invented the first dental X-ray tube in 1913, and then we had our first kind of more modern, I guess, unit in 1923. And I don't test a lot on dates. I personally, I don't love like remembering laws and rules and historical dates. So I don't usually test on that kind of stuff. Just, even though there are these in the PowerPoint, I don't tend to ask questions on them. Digital X-rays, more modern. So they have been around for most of my career in the 2000s to, like 2000 to 2010. I never used digital. I was all traditional film. And then I think I think the first place that I started using a digital sensor was in like 2011 when I went to work at a general practice. So I didn't, half my career I wasn't using digital, but like I said before, pretty much now most offices use digital. And in the 80s, early 90s is when it first started coming around. It was probably the highfalutin, like fancy schmancy offices that got them, or or a dentist that loved technology and like everything new and techy. But in general, I would say in the last probably 10 to 15 years is when we've seen the biggest change where more and more offices are going to digital. Yes.
Would you say like these PowerPoints are your main resource that we need to look at for your tests and quizzes?
So the textbook is absolutely, I pretty much would say yes. The PowerPoints, I put a lot of information. If you study these PowerPoints, you will do fine on the exams. However, I say that with the caveat that there's a lot of sort of some of the ideas are more complex, especially around the sciencey part. And so sometimes the way I say it or the way I present it on the PowerPoint, you might still feel like it's a muddy waters topic. And so your textbooks are wonderful resources, and not all Darby and Walsh, there's so much material in there. So I wouldn't always say just rely on PowerPoints, but at the same time, I do tend to put a lot of information on the PowerPoints because I want you guys to feel confident in what you need to study. Because with so much material, that's usually the number one question I get from students is, what am I supposed to study for the exam? So I do tend to put a lot of information on the PowerPoint, and then you have a better kind of concept of what you need to study. And unfortunately, less and less students are buying textbooks. Would you guys agree? Would you guys agree with that? You probably don't want to tell me. It's fine. But yes, so I do tend to make them pretty thorough. Okay, so dental images and the dental radiographer, that's the word, radiographer. So generally, obviously in an office, dental assistants take radiographs, dental hygienists take radiographs. Very infrequently, the dentist may take a radiograph. But those are basically the people. The importance of it, we already kind of talked about the importance of it. We have to get this in our heads so that we're comfortable talking to patients about it. I am one of those people that if my patient is very healthy and they have good oral hygiene, I am not going to make them feel guilty for skipping a year of bite wings. The dentist might have a different philosophy, but if they haven't had an active carious lesion in 5 years and they brush and floss, I am not in a panic that they didn't want their yearly bite wings. But at the same time, you may be at a practice that are just run very kind of like every 6 months, every 12 months, every blah, blah, blah. And so then you have to be in a discussion about the the protocols in that office. Now, ADA does talk about guidelines and overprescribing and underprescribing. However, a lot of offices rely on insurance to dictate. If we don't want them to, that's not ideal, but so many offices fall into that where they pay for bite wings once a year or even twice a year if it's a kid. And so that's what we do. We take the bite wings once or twice a year and they just do it automatically. So some patients are going to be more vocal because they know that X-rays, radiation does cause some biological harm. And so they might advocate for themselves more. But it is important, I think, for you guys to have the general understanding that it is a small amount of radiation. You're not gonna kill yourself like Renkin did, taking like way too many X-rays. It's a very small amount of radiation. And because the digital format is out, it's even a quicker flash when you push that exposure button and radiation comes out of the end of the tube head. It's even a shorter exposure time than it used to be with traditional films. So it's very fast, it's very short, it's very low dose. The other thing is we use a rectangular collimator. And when you look at the actual unit in the X-ray rooms, it comes out rectangle instead of round. And so the surface area that is being exposed to radiation is much smaller. So our patients, because you guys might have to take retakes, our patients are exposed to far less radiation. So in general, you can kind of quell your patients' fears about radiation. But at the same time, if they're very healthy, if they've just gone through cancer treatment and they've had a ton of radiation, maybe you do put it off a year, and that's okay. But it's kind of this risk versus the benefit. It's risk benefit analysis. How much radiation have they had? Do they really even need it? Or how healthy are they? Do they have a lot of disease and we just want to see what's going on? And these are other reasons, like we've already talked about, all these different reasons that we're just not going to be able to know the answer to give a patient about something if we don't take an X-ray. So sometimes you have to, like debate with your patient and then to come up with like, okay, well, just let me take at least one PA in that area that's bugging you. So sometimes you have to, come to that agreement. Duties and responsibilities, positioning and exposing the dental X-ray image receptor. So your biggest responsibility is learning how to take a good X-ray. That's the whole point. Diagnosing oftentimes is going to be the dentist, but you need to learn how to, with your patient who's going to be varying depending on their anatomy, their ability to withstand, something being shoved down their throat. So all of these variables, you have to learn to mitigate that situation and take the best diagnostic film that you possibly can. So that's your main goal and role as a dental hygienist. Data retrieval from the digital imaging, everything's so automatic, even mounting very oftentimes is automatic. Sometimes it does come into the computer upside down. So you get tested. I test you on mounting. You have to know anatomy. What's anatomy that you'd see down on the mandible? What's anatomy that you'd see up in the maxillary area so that you can mount the films in the right place. But very oftentimes, if you click on the box that you want to take the picture of, the X-ray will just go right into the box. And so you don't mount as like we used to mount. We used to take image by image by image, but things can still come in upside down for whatever reason. Software gets funky. So you do have to know how to mount the images in the right places. Educate the patient about dental imaging. You need to feel confident, like I said, about the risk benefit analysis and be able to talk to them about exposure to radiation. Implementing, monitoring quality controls, and then ordering dental X-ray supplies may or may not be your responsibility. It might be, some offices do, some don't. Okay, our priorities is protect the patient from overexposure. So that's critically thinking, appraising, executing your best job the first time. It's so easy to get flustered and just be like, I'm just gonna shove this thing in their face and hope it works out. Once you actually like have a real patient, because it's scary. You're short on time. You haven't done it before necessarily, or maybe you have. So this might not be your scary thing, something else might be your scary thing. But really, like taking a minute to evaluate where you want to place the sensor, where the direction of the PID or the part that sticks out that you can move, and we'll go over all of those parts later. But the angulation, the placement in the patient's mouth, is my patient sitting up straight? Do I have the setting on right? Is everything where it should be so that you don't have to expose the patient again? So something that happens with Dexter every year, totally happens all the time, is the ring is upside down. So then, everything gets set up. You think you are going to take a beautiful picture, you set it up, you go out of the room, you push the button, and you come back and it's black. And it's because like there was no exposure happened. There's nothing there. And so that can happen also with a real person. Well, you've radiated them. You just radiated them here instead of here. So, things like that. It's part of your role and responsibility to think about all of those steps and making sure that you're taking a film the best way you can. Yes, there will be retakes. That's part of it, but do the best you can the first time to try to minimize retakes. Operator protection, protect yourself. If somebody is gagging, if somebody have just a challenge, it's tempting to be like, I will just hold this here, go take the shot. But if you do that over and over and over again over a 30-year career, that's a lot of radiation that you've absorbed for no reason. And so you have to find out a way to take a film on somebody without exposing yourself needlessly. So you should be out of the room when you push the exposure button. Competence, efficiency, high quality films. Okay, so we have two different kinds of machines. We have extraoral machines, pano machines, and cone beam or CBCT. Okay, cone beam. What's the other CT, my dental assistants? Cone beams. What does CT stand for? My brain is just too tired to think about this. It's gonna come to me and then I'll be mad at myself. Cone beam, CBCT. Okay, don't worry about it. We'll learn it later. So intraoral and extraoral. So extraoral means that the film is outside of your mouth, right? So the film is outside of your mouth, the source of the radiation is outside of your mouth, and that takes that's what takes the CBCT scan and the panoramic film scan. Intraoral is the sensor is inside of your mouth. So still the radiation is coming from outside, but the sensor is on the inside. So those are the difference between external and internal films. We also have this little handy dandy guy. This you'll mostly use when you're out on rotation with Professor Ramirez. He has a Nomad out on his bus, the big mobile bus that we take to all the different places. So you'll use the Nomad when you're out on rotation, but we'll learn it in my class about halfway through. We'll have a lab where you guys will get to practice with the Nomad. And it's just a wireless, you stand behind it, so you are there where the radiation comes out, but that little donut that's around it, it makes it so any scatter, like, because radiation always it goes in a straight line, but it dissipates. It kind of goes off at like an array, like a flashlight, the way light kind of disperses. And so when you stand straight behind it and there's that little ring, it deflects it around you. So it seems like magic to me, but that's what it works. Okay, so the parts of the machine. So I kind of color coordinated this. So note the tube head is sort of the back portion here. That's the tube head. So the blue goes with blue. The positioning device, I refer to it as the PID. The PID, that's the positioning device. And that's the part that sticks out. So like the little beak. That's the red circle. That's the PID. And then the control panel, there it is a control panel on the inside of the unit sometimes, not the ones that we have, but sometimes you'll notice that with some of the units, but like 100% of the time you should be leaving the room to push the button. So the control panel should be outside of the room. So it just depends on the setup of the office. But those are the main parts of the intraoral. Some of the different receptors that we'll use. So these are this exact setup here with the yellow and the blue and this red one and this with these three colors here. This exact whole setup is what the seniors have. You guys are going to be using a brand new set that I think is going to be and so don't go around bragging. Once you're comfortable and know each other, don't go around bragging to the seniors because they're going to be sad. But this is what the seniors have. So if you see this set, this is what is, there's a lot of these in clinic. But we're going to learn on a different set and I'll give it all to you guys on Wednesday. And I'm really hoping it works. I hope you guys like it. And I think it's going to make your lives a little bit easier. One thing you will notice about these is that they're very chunky. So do you see like the yellow ones? See how there's yellow plastic above and yellow plastic below? Same here with this blue one. It's like plastic here and plastic here. They're chunky. And basically anything that's big that you're trying to fit into a very specific spot is it's just more uncomfortable. So we got ones that I like better because I think they're going to be more comfortable for patients. And you'll use them on your patients for your spring and senior year. So these collectively, this set, these are called XCPs. I don't remember what XCP stands for, but that's what they call them, or XCPs. They're positioning devices. They're basically a target ring, a bar that holds a bite block, and those pieces all put together very simply align the tube head and the PID with the sensor that you have placed in your mouth. So it's a whole unit that works together to make it kind of foolproof, although it's not 100% foolproof. But those collectively, we just call them XCPs. And then the snap array is another one. This is one that, sometimes if you have a hard time getting the XCP in a patient's mouth, we'll use a snap array because there's not so much stuff. You can kind of slide it in different ways. And sometimes you can just locate the one tooth that you need a picture of. And then there's also little tabs for bite wings. And I'll show you guys those in lab. So those are just some of the tools or the equipment that we'll be using. So now we're going to shift gears and talk about the types of radiographs. So like I said, this is going to be very, very basic and review for any of you who have taken films. But for those of you who have not taken films before, you've had probably these films taken when you were at your dentist's office. So the only one that you might think looks very foreign is the one with the green outline. The one down, it says down at the bottom, occlusal image. So an occlusal image is something that we'll practice. It's not seen a ton in private practice, but I would say the best example is in a pedo office when they're trying to take anterior pictures on kiddos. So a lot of times they'll slide the sensor in like a sandwich. And if the top part of the smooth part of the sensor where you aim it toward the PID. If that's for a maxillary shot, they'll have that facing up and they'll just slide it into the patient's mouth like a sandwich and then put the PID over their nose and then capture an image and then flip the sensor around. So now the smooth part's facing down and then have the PID come up under the chin. So that's what that is showing is those are mandibular anterior teeth and the PID basically came up like at a very sharp angle like this. The film or the sensors in their mouth and the PID comes up like that. And there is still some legitimate uses for that kind of a film. Some people have salivary stones, and so it's a great way to image the salivary stones, or again, but I think the most common is like for kiddos because it's easy. They just bite. That's all they do. They just bite on it like that and it's easy. So an occlusal film, you're not going to use it a ton, but those are situations when you would. You will do a lot of PAs, periapicals. We just shorten it and say PAs. Oh no. Does anybody have does anyone have a charger I can borrow? It's the kind that has like the skinny oval, like a skinny oval.
It's like a microphone.
Yeah. Normally I don't lecture all day. Is that one? Yeah. Thank you. Fabulous. Now let's just make sure I don't trip over this cord. Thank you all for whoever, all the rummaging in the backpacks. I absolutely appreciate it. Normally I just don't lecture. I had morning with the seniors. Is there a, no, these don't work anymore. No. I'll just have to scoot this over. There's a one behind me. I just don't wanna. Will it reach? Yeah. Okay, don't let me trip over that. I can't move. I'm gonna be stuck right here. Okay. Thank you very much. That's very helpful. I gotta get my water. My throat is so dry from talking all day. Okay, so the ones that we're going to use a lot are periapical radiographs, PAs, and there's two types of PAs. There's anterior, which is our anterior teeth is from our canines forward. Those are our anterior teeth. And then we take a posterior PA, and our posterior teeth are from our premolars, the teeth right behind the canine, back. So if we're taking a posterior PA, it usually involves premolars, molars. Sometimes, yes, we want the distal of the canine, and we'll talk more about that later. But if it's an anterior, then it's going to be canines forward. So those are the two types. You can see anterior is generally speaking going to be rectangular going long ways, and posterior is going to be rectangular horizontally. It's going to be rectangular going right to left longer. And then the anterior is going to be rectangle in a vertical up and down. So that's another way to kind of recognize what you're looking at. So posterior PA, anterior PA. Bite wings is the one with the red, and that you're going to see half maxillary and half mandibular. You'll always see half and half. And those are the ones that we call them like the ones where we can see early decay. Those are the ones that are usually your yearly checkup x-rays, are the interproximal bite wing radiographs. This is a couple different examples of an FMX, a complete mouth series. This is very common if the office that you worked for has DEXIS. This is what the DEXIS software looks like. This is older because these are traditional, so they're mounted in this plastic mount. So all these individual films have been mounted, but they all are made up of the same thing. They're made up of 18 films altogether. You have posterior PAs here, 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 and here. And then in the middle, these four in the middle are your bite wings. And then in the very center, you have your anterior PAs. So it's always set up like that. It does not defer. The only things that changes is if they're missing teeth. So if they're missing all their maxillary right molars, then you might not have one of those films. But other than that, it's always set up in the exact same way, and you're always trying to get the same teeth in those pictures. And our criteria is very strict. We concentrate on a few very specific things that we want to see every time. And it's because it will help you know where to place. And so if we don't see those things, then we're just going to mark those criterias off. It doesn't mean that you have failed or necessarily even that the picture is undiagnostic. It just means that we want you to recognize your placement being off And so that maybe you can work to place it maybe a little bit better if at all possible, because sometimes the patient's anatomy dictates that. This is a panoramic image. So this is this intraoral or extraoral? Extraoral, and you can see the whole jaw, you can see the sinuses, you can see the TMJ up here, the condyle, you can see even this is the ear. Do you see that? If you kind of squint and look sideways, this is the ear. Over here is the other ear. And so you can see just all kinds of stuff. And when we talk about the landmark exam is anatomy as seen on a pano and as seen in an FMX. So those two images, all the different anatomy that we can see, we learn that anatomy, and that's what the landmark exam is. So that's a ways down the road. Don't panic about it, but that's what we're testing on when I say landmark exam. Okay, so the teeth on a radiograph. So the first one here, any guesses as to which tooth that is? Oh my gosh, you're going to give a number? That's advanced. Let's just leave it to that's good, but let's just leave it to a name. Canine, right. So this is the canine. Now this is tricky for those of you who haven't looked at a lot of teeth. This one is kind of tricky because this premolar is kind of pointy. So a lot of times when we say identify the canine, we're looking for a tooth with a longer root, because canines have longer roots than usually the other teeth. And then we're also looking for a tooth that's kind of looks a little pointy. So longer root and a little pointy. And so it's usually fairly easy to recognize on a radiograph, but some people clench and grind and they flatten stuff out. Some people have different shaped teeth just in general, or the angle that you took the x-ray, it can look kind of funny. So, but yes, that's a canine. The other thing is look at the teeth on either side. This one, yes, looks kind of pointy, but you can see it has a facial, an outside and an inside cusp, or a facial and a lingual buccal and lingual cusp. And so there's two cusps. So dimensionally, it's not just this thin tooth, it has like two mounds on either side. So you can kind of see that in the picture. You can see that here and you can see that here. So that kind of makes you think, that looks more like a tooth that's more toward the back or in the posterior. And then as you look on the other side of it, this looks boxy. Well, all of our incisors look kind of boxy. They all look kind of like rectangles. Okay, what about this one? Any guesses? Just a name, not a number. What? Premolar, yeah. So this is specifically, it's the first premolar. It's over on the left-hand side, but that's too much to think about right now. We're just going to deal with identifying the general teeth. So we got a premolar, second premolar. So first premolar, closer to the anterior, second premolar, the next one back. So those are our premolars. What about that guy? Molar. So would you think it's a first molar or a second molar? Mm-hmm. First molar. And then that leaves these guys. So the ones very, very in the middle are our central incisors, because they're in the center. They're at the midline. So we got two central incisors, and then the other two incisors that flank it are our lateral incisors. They're lateral to the central incisor. So those are our incisors. And those mandibular or maxillary? Mandibular. Yep. Mandibular. So they're down here on the mandible. They're the teeth that are down on the mandible. Okay. Oh, is this a thing? Did I put another thing? How do we know? Oh, wait, I can't remember if I added a activity here or not. How do we know we've taken a good image? We critique our work. Is there a thing here? I don't know. I don't think there is. Okay. But that's basically what I'm saying here is, especially, and even if you have taken films for a long time, if you have never taken films and you take a film and teeth show up, you usually want to celebrate. You're like, oh my gosh, I took a film, there's teeth. But now we have to think, okay, did we actually place it in the right place? Is it showing anything diagnostic? Did I do what was meant to do? So this form is going to haunt you for the next 2 years. You're going to see it every single day in lab. You're going to see it every single day in patient care. And I have lots of worksheets. So we're going to critique until you're like blue in the face and you're like, I hate critiquing. And so we're going to go over this I think I'll go over it on Wednesday because there's a lot of details to it and I want to print it out so you guys have it in front of you and you can make notes on it. But this critiquing form is where we look at each one of these boxes. So this box here and this box here, they all line up with the FMX, right? So in the middle here is our bite wings. And then we have our molar PAs, mandibular molar PAs, mandibular maxillary, and then our our anterior PAs. So it matches up with an FMX and we just use it to critique our films, see if we have all the right criteria, if everything is lined up. And if you notice down here, see how it says Spring Junior 5-2 retakes? What that means is that next semester, when you actually are in patient care and you're actually taking films on your patients, when you take a bite wing, set of bite wings, which is 4 films, if you get 2 of them like pretty near perfect, but the other 2 need to be retaken, then you can still, well, can you pass? Does that mean you can pass? Yeah, you can pass. So as long as half of them are diagnostic and you don't have to retake them, then you can pass that set. But if you have to retake 3, then you cannot count that towards your requirements. So this sheet is used the whole way through because as you see, fall, bite wing stays the same, but the first number is for FMXs. So out of the 18 films, you can have 5 retakes. In your spring junior year. In your fall senior year, you can only have 4. And then in your senior spring, you can only have 3 retakes. And that can be challenging because you don't, your patient's anatomy and their tolerance and just all of it can affect it. But that's how many retakes you can have. And then we also add up technical errors. So if you cone cut or you have a beam centering error or you overlap contacts, and we'll talk about all those things, those are technical errors that either you didn't identify, if it's there and you didn't notice it, then it's gonna 1 point for each unidentified technical error. So if you notice it and you say, I closed the contacts, it's not going to be counted against you. But if you don't think it matters or don't pay attention or just forget or whatever, then that would be a point against you and you can only have 9. So we test the same way in lab to get you ready for patient care because it's always, it's brought all the way through until the end. So technical errors and retakes, they're 2 specific ways that we critique. And we'll talk a lot more about that in the weeks to come. But just to give you a taste of what we're talking about, so an error is anytime we take a film and something didn't work out the way we wanted it to. So something didn't work out quite right. So there's basically like 4 main errors that you need to become familiar with and memorize. The most common, easiest one to remember is horizontal angulation error. Absolutely the most common one. You'll see it all the time. You should be able to pick it out like easy. Like, oh, there's horizontal angulation. And all it is when we look at teeth, are they overlapped? So does it look like those teeth have been taken, the picture is taken like this, or does it look like the picture was taken like this? So either right next to each other with a little thin black line, or the picture looks like it was taken where there's overlapping. So you'll just get used to seeing it. Like, would you say there's horizontal angulation here? No, but would you say there's horizontal angulation here? Yes. And it can be little, it can be big. Like this is like, oh my gosh, what happened there? Like that's really obvious, but it can be just a little bit. And we'll talk more about the details of that criteria. But that's one of them that you have to be aware of. Placement is another one. So what do you think is missing? Granted, we haven't talked much. Some of you have just barely are starting to learn some terminology, but What do you think is missing in this picture? The whole tooth, right? Like the bottom part of the tooth. So one of the biggest things when you're taking a PA is you're trying to see the very base of the roots and the bone around it. And so this one has a placement error where it has cut off the bottoms of the teeth. You can see more black space up here and it's cut off down here. This a lot of you who've taken films for a long time, you would just call this a cone cutting error. It's cone cut. It means that the sensor is here, like the sensor, you place the sensor in the mouth and the PID got placed like this. So all of this down here, or all of, actually, sorry. So it's got placed like this. And so all of this up here is white because that part of the sensor didn't get any radiation at all. So what you're going to do is you're going to move the PID in the direction of that cone cut. So if the cone cut is off to the side, then you have to maybe move your cone just a little bit off to the right. If it's at the top of the image, you got to move your cone up a little bit. So it used to, most lame, or not, it's not layman's, but most people in dental practices think of it as a cone cut, but we call it a beam centering error because your beam was not centered over the sensor. So it kind of describes the error a little bit better. The radiation X-ray beam was not centered over the sensor. So you cut off some of that, that film didn't get radiation. So that's what this white line is. So now what about this? Does anyone think that's a beam centering error? Kind of tricky, huh? It's part of the XCP. A lot of times you can see some parts of the XCP, and the way that you'll be able to tell that that is not a beam centering always travels totally straight across. So even if, let's say it went from here to down to here, it would come all the way down and off. It would never do this like over down. Do you know what I mean? It would never be like partial. It would just go all the way because you're talking about the edge of the PID. And so it will look different. So here's another example here. This is a beam centering error, and see how it's going straight from one all the way over. It's not cutting off halfway and just going straight down. It's going like all the way across. And it might look a little different, but it will never end in the middle of a film. It will always go from one side to the other. And if it does end in the middle, it'll end at a sharp slant. It won't like be like a right angle. So that might not click, and you might ask like, is this beam centering? Is this that? And you can ask that with different examples because sometimes it takes a while to figure that stuff out. Okay, so density. So we have different densities. We look at a film and we see shades of gray, we see black, we see white, and then we see all these different shades in a film. Basically, what you're looking at is how easy or hard was it for that X-ray beam to go through the matter? So if something goes through like air, is that hard or easy? Easy. There's nothing really to absorb the X-ray. There's really nothing to stop or scatter the X-ray. And so that X-ray hits the sensor with very little resistance. So you can think about it as full power X-ray. So those are your darkest areas on a film. So anything in the mouth that is gonna be more ushy-gushy, like gingiva, that's soft and lots of blood vessels, nerves inside the tooth, blood vessels, there's nerves there. The gaps between teeth, there might not even be gingiva there or gum tissue. It could just be, again, like air. all of those areas are going to show up black. And then the bone, which you're looking at a lot of bone, there's a lot of bone all through here. Bone has, it's a matrix. So some parts are dense and some parts are less dense. So that's why you're looking at like this webbed effect of like shades of gray. So all of these areas, this is where gingiva would be. See this nice, thin black line? That's a nice open contact. Over here, we have a little bit of an overlap. This is just airspace between the top and bottom teeth, or where the bite block was placed. But then we have these really bright white areas where it's a lot more dense. So what is that taking a picture of? Enamel, exactly. So your enamel is hard, it's very dense. The matter is just very, very dense. So it's going to come out white. And then you're just going to be across the spectrum, depending on what you're looking at. And doctors use that to help with diagnosis. If you're looking at an enamel and there's a break in the enamel and there is this displaced gray, dark area, what are you automatically going to think you're looking at? A carious lesion, yeah, because you're thinking, oh, it should be solid white all the way through. Oh, there's a break. What's that? And then decay tends to show up a certain way, and we have a whole unit on that. But there's literally material gone, and so there's less matter. So that's the X-rays go through that carious lesion at a different rate. There's more radiation that hits the sensor as it goes through the carious lesion, and that's why it shows up dark. Okay, so all my squiggles, aren't these fabulous? So the radiolucent, so we have I should have switched these. No, that's good. That's right. Never mind. So radiolucent, dark areas. So if something is translucent, you can sort of like see through it, right? So translucent paint is more like you can see through if it's translucent paint. So you can think radiolucent, it's X-raying things that are less dense. Radiopaque, you can think of like if it's opaque, it's white. Opaque paint tends to be like a thicker paint that you can't see through as much. And opaque is of course white. So white areas on the film. So you have, for the radiolucent, you have less matter to penetrate. So more X-rays get to the sensor. For radiopaque, you have, I don't know if I even read it the first time. Did I say it right the first time? My brain just kind of shut off halfway through. So radiolucent, you have less matter, so more X-rays get to the sensor. For radiopaque, you have more matter, so less X-rays get to the sensor. So I'm just pointing at like where the gingiva is here, or this. What do you think that is? Bright, 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 bright white. An amalgam. So it's metal. So the denser material is just going to show up whiter. The more dense it is, the whiter it is. Okay, so I think I'm going to skip this. You guys can do this, I think, on your own. It's just where you pick out, you pin whether or not you think it's radiopaque or radiolucent. And I just feel like you guys probably maybe got that. And it's this little scale here. So radiopaque white, shades of gray. So if something is more, it's all relative, right? So if you're looking at something that's like black and then gray, you're going to refer to that gray area as a little bit more radiopaque. It might not be white, but if you're talking in relation to just those two things, you're going to be like, well, this area is a little bit more radiopaque, even though it's gray. But if you're talking about something in comparison from white to black, then that spectrum is much wider. But sometimes we talk about things just in comparison to two values or two densities, even though it might still be, the gray is going to be more radiolucent than something that's even lighter still will be more radiopaque than something gray. But it's all on that, that's color spectrum, or that value spectrum, I guess. Okay. What time is it? I think we can, should I just power through, or do you guys need like 5 minutes? Power through. I know my voice is like, it's gonna like, and then I have to talk tomorrow morning. I don't know how I do this every year. Okay, let's power through. Okay, Objectives. If anyone has to just get up and stand in the back of the room, you can. No, but nobody is going to be like, you have to sit in your seat the entire time. If you just need to get blood moving, it's okay. You know, maybe not the whole class at once, but if someone needs to get up and stand for a few minutes, it's totally fine. And of course, also if you have to use the restroom or something, you can get up and use we're all adults here. I don't think anyone's, going to run out the door and never come back. So you're always welcome to take a bathroom break if you need to. Okay, so we have some objectives here. This is all right now. We're just going to focus in on bite wings. So we have some terminology. So this is stuff. This is not fluff. You'll probably need to revisit this when your brain. I'm sure your brains are overloaded. So you are probably going to have to revisit this. Because these are all important things. This is, like I said, it's not fluff, it's important stuff. So interproximal is a term that refers to just between two teeth. We're talking about the space between two adjacent teeth. Typically they touch. They touch somewhere very lightly. There's a contact. Sometimes there is no contact and it'll look like a diastema. I have a diastema between 8 and 9. And so my teeth are next to each other, but they don't touch. And so you will find that, but generally speaking, that interproximal space is the teeth touch. Interproximal examination, intraoral examination used to inspect the crowns of maxillary and mandibular teeth on a single image. So a bite wing is an interproximal examination image. That is the main film that they're going to use to look at that interproximal area. And it's highly accurate for diagnosing incipient caries, just little tiny caries that are just starting to form, and bigger ones. Bite wing receptor, it's the type of receptor used. It's the type of bite block that we use. And we'll look at them on Wednesday when we open up your whole kit. There's usually like a wing or a tab that the patient bites on, and that's where the bite wing part comes into play. And it just stabilizes the sensor, gives a target, like a place to kind of focus on. Alveolar bone is the bone in between the teeth, the bone that supports and encases the root of the teeth. So a lot of times we're looking at the bone, that little crest of bone that is between the teeth. We're also evaluating all the way around the roots and in between roots, but a lot of times we're focusing in on just that part that is in between the teeth. Specifically, it is called the crestal bone or alveolar crest. And we'll look at some images and kind of point that out. But that's usually just that bone that is kind of rounded or maybe a little flat, squared off in between each tooth. So we want to see that bone on a bite wing. It's really important that the bite wing shows us at least that much bone. We don't really expect to see much more than that, but we want to see at least that. Contact area is where the teeth actually touch. So the interproximal space, but the contact is the exact spot where they actually come together and touch. And then there's two kinds of bite wings. We have horizontal bite wings. I always just think of the word horizon. The horizon goes from east to west, right? East to west. So a horizontal bite wing, the rectangular sensor is going to be long from right to left. It's a horizontal bite wing. And so it has to do with directional placement. A vertical bite wing is the exact same sensor, and now we're just flipping it 1 degree. So now the length of the rectangular sensor is going from north to south or up and down. So it's the same sensor, we've just turned it vertical instead of horizontal. So pretty straightforward there. Open contacts is our goal to take the picture so precisely that the little X-ray photons that come flying out of the X-ray tube head go straight through that contact with hardly touching either side of the tooth. That's what makes the contact open and look so clean and nice, is you got the angulation of your PID in just a way that it just flew right between the teeth. And so it didn't pick up a little of one tooth and a little of the other. It just went right through the contact. Kind of easier said than done, but we talk about how to do it in lab. Overlapped contacts is when you nick a little bit of the front of one tooth and the back of the other. So it nicks a little bit of both tooth on the way through. And so then you get an overlap. And like I said, we'll talk about that more in lab. So the purpose, early detection of caries, the ability to detect decay around margins of fillings. Dentists will look at these old fillings, they'll look at crowns, they'll look at the margins in all these areas and just make sure that everything is looking good. You can see because can anybody see the difference between like this right here and let's say like this up here? Or even like this over here. Do you notice anything happening like right there? And then there's like this big old shadow. So that's what the dentists are looking for. They're looking for breaks in continuity. They're looking for shadows, and your eyes just get trained on it. The more you look at it, you start to see it. We're also looking for accurate representation of the bone level. So because of the nature of a bite wing, because the beam, the X-ray beam is coming in nice and perpendicular to the sensor, it's like this really nice angulation that gives a very accurate image. You get a very accurate sense of the level of bone. So sometimes we take pictures at these steep angles and it distorts the bone. But when we take a bite wing, we come in at a really nice angle. And so it ends up giving a very accurate image of the bone. And so that's another very useful reason for bite wings. Okay, so the criteria, so you just have to memorize this. It's just, you're just going to have to know it. You will know it, but it's just one of those things where that's why I'm like, start knowing it now because you're just going to have to know it. So 2 types of films for a bite wing. We take a premolar and then we take a molar. And so this example here shows us the criteria that we need for our premolar film. We want to pull the sensor far enough forward in the patient's mouth that we get the distal portion or the back half of the canine top and bottom. So when we look at a premolar shot, we're going to say, can we see that back half or that posterior, or really the actual thing that you're supposed to say is the distal portion, but I know that the word distal is probably like Greek to some, at least half of you, you're like, what the heck is distal? But it's the distal, it's the back half of the canine. And we want to see that back half of the canine on a premolar shot. And then we want to see our premolars. And usually we want to see the first molar. Will we see the second molar like here? Not always, and that's fine. We don't really care. We really want to see the distal portion of the canines. That's our major criteria with our premolar bite wing. For our molar bite wing, it's over here, we want to see, oftentimes we'll see the distal portion of the first molar, and then we'll see the second molar, and we want to see the third molar space. Now, in our clinic, a lot of our patients have their third molars. So we take a lot of bite wings with third molars in the picture. But in private practice, in general practice, a lot of times general dentists want to rip those out. So your general population in a private practice might not necessarily have a wisdom tooth, but they may or they may not. So the criteria is we want to see far enough back to see the third molar space. Now, what we do in our clinic is we zero in on the second molar and we center it in the film. And we'll hit that harder and talk about it a lot more. A lot of the examples of molar bite wings, the second molar, if you just look out in the world, the second molar will not be centered. But we focus on it here because it forces you to push the sensor back in the mouth far enough. Once you're comfortable, it's not like you have to get it back that far. But while you're here, that will always be a criteria that you need to try to meet, or at least recognize, did you do it or not? You know, some patients just simply won't let you get back that far, but you can at least recognize where your second molar is and then where is it front to back and how you placed it. So criteria, so all posterior contacts should be open with no overlapping. So if we're looking at a premolar film, we want to see open contacts around all the premolars. So between the second premolar and the first molar, between the two premolars, and between the distal of the canine and the premolar. Now this is closed. So the story is that it doesn't always happen perfect. And that's just life because you're dealing with a rounded arch and you're trying to take pictures on corners. So we do it as best as we can. That's the goal, but it doesn't always happen perfect. For a molar shot, you want all of the contacts around the molars open. So if you're looking at a premolar film and you've closed a molar shot, you can recognize that there's a closed contact, but it's a premolar shot. So your goal is to open up the contacts around the premolar teeth. The film should show equal amounts of maxillary and mandibular teeth. You should see the alveolar crest. This is the alveolar crest. This is the bone between each molar. And you should see a good half and half. It should be fairly equal. So that you can see a good amount of alveolar bone between each tooth. Hopefully there's no beam centering error or cone cutting. And then hopefully the contrast and density, like the lightness and darkness of the film, is pretty even. And we talk more about how that happens but see how I just threw up these little lines because basically you want that X-ray beam to just fly straight through those areas. Okay, one thing that you'll notice when you're taking a bite wing is that the receptor, the X-ray beam I'm talking about the receptor over there, sorry. So the X-ray beam is going to be coming at a very slight downward angle. So we call it a positive degree. It's coming at like a positive degrees, like 7 to 10 degrees. So it's an ever so slight downward. Sometimes it looks really flat. It kind of depends on Dexter too. Honestly, don't let Dexter drive you crazy because sometimes you're like, it's not 10 degrees. And that's just the way Dexter's mouth is. But generally speaking, it's somewhere between 7 to 10 degrees. And then this is showing the central ray or the primary beam going through the contacts. It's just showing from an occlusal surface how you want the beam that's coming out of the X-ray to sail through the occlusal surface of those teeth. So central ray is what we're always kind of focused on. It's the invisible beam that's coming out of the tube head. So this is just showing again, like this is positive angulation. So this is the PID is pointing downwards. And I know that might seem counterintuitive, but that's positive. If the PID is pointing up, it's negative degrees or a negative vertical angulation. And then if it's just straight across, or parallel to the floor, it's 0 degrees. Generally speaking, you're taking X-rays on a curve. Generally speaking, you're going to be a little bit straighter when you're taking a molar shot, and you're going to be a little bit more kind of your PID is going to be coming in a little bit more to this angle when you're taking a premolar shot, and then you straighten out a little bit for the molars. But that's not a good rule of thumb to just be like, it's always that way, because there's a flare to your jaw, right? Like the arch is flared. So you're always going to want to sort of follow that flare in order for the beam to go interproximal between the teeth. We have all kinds of different kind of little variations and tricks that we talk about, especially if you're having a hard time setting it into somebody's mouth far enough back. But in general, this is sort of the general placement that we go for. So when we look at our patients, the premolar shot is the PID is going to be a little bit closer to the front. And then for the molar shot, it's going to be closer back toward the ear. You just have to a lot of it is visualization. Like you just have to sort of visualize and get used to thinking about where's my sensor, how far front or back. And then you can also have your patients bite and smile. And sometimes you can see some of the sensor, and that helps too. Like you can kind of see where the sensor is in their mouth. So when we go back to the errors, when we were talking about the 4 main kind of errors, there's placement errors, there's horizontal angulation errors, there's vertical angulation error, and then there's the beam centering error. So when we go back to the placement one, the couple different things can happen with bite wings. The biggest errors that you'll see is beam centering. If you get that PID out of the ring, or you don't close it, you don't have all four corners touching the ring, you can get a beam centering error. If your vertical angulation is too deep, so too far positive, like say you go beyond 10, you're at like 20 or something, or you're negative, if you clip did my other picture, let me see, hold on. I feel like there's a picture somewhere, but if your vertical angulation is too deep or steep, you could clip this back part of this cusp and then clip this front part of this cusp. And what you'll end up having is this. See how it's overlapped? So the vertical angulation was too steep, and so they clipped the lingual part, or no, they would have clipped the buccal part first, and then the lingual part, and then it hit the sensor. So that's vertical, and you can see it here too, really, really good. See how those cusps are all overlapped? So that's what vertical angulation error looks like on a bite wing. It looks different on a PA, and we'll talk about that later, but that's vertical angulation. So that's a placement error. We also have, so premolar, distal of the maxillary mandibular canine not visible. So if this is supposed to be a premolar shot, they didn't get anywhere near close enough to placing it anterior enough. So that's a placement error. This next one here, molar, distal of the third molar not visible. So way up here, we can see some third molar down here. We can see a third molar here, but it's cut off the backside of this molar. This one you can kind of see it a little bit, but not the full backside of the molar. So again, a placement error. It wasn't set back far enough in the mouth to expose that part of the tooth that they needed to see. Film not centered. You can see way more mandibular teeth than maxillary teeth. Tilted, it's just kind of wonky in the mouth. So those are all placement errors. Horizontal angulation errors, again, we're just kind of revisiting this. You can see these interproximal spaces are overlapped. Look at how fine it is. See how little there is overlapping here and here, 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 and even here. Look how teeny tiny that is. But you see where the contacts are open, you see a thin black line. So you see, and that is what allows you to see this, like things like this decay. If you have these this is not so bad. A doctor could diagnose it, but if you have this overlap, it might hide decay that's interproximal. So it's really, really, really important to open up your contacts for all your teeth. So this concept is so important. It's challenging. It's frustrating. It's what the number one reason why we will end up having to do real life retakes on patients. If you can't open up a contact, if the contact is closed and the doctor can't see, they're going to make you do a retake. So that doesn't always happen in private practice because sometimes dentists are just like, oh, I can see it fine. And who knows what they use to determine that. But here, if you don't have every contact open at least once, you're going to end up taking a retake. And that's true on live patients. And so that's why we just want you to do the best you can the first time and just try to minimize it. But it will absolutely happen because it's just challenging. It's really, really challenging. So this little thing is just showing how the center one, see how it slides right through, but this one, the horizontal angulation is off. So that beam going from left to right is off. So it clips a little bit of this buccal cusp and a little bit of this lingual cusp. So it clips a little bit of both, and that's what makes the overlap. Vertical angulation, I feel like this is the one I was thinking of, but I think I described that already pretty well. It clips a little bit of the buccal cusp and a little bit of the lingual cusp, but from a vertical angulation, not a horizontal angulation. And then beam centering error again. Now this is a round cone. We have rectangular cones, and so all of our beam centering will look like straight lines. This is from a round collimator. So the collimator is like this, so the beam centering error looks like that. So that's the difference there. And then other errors, if the film is too light or too dark, that has to do with density, contrast, You can change a few things on our x-ray machines, but you cannot change a ton of things. So sometimes a film just comes out lighter, and we'll talk about some of the reasons why that happens. Other things are patients gag. Sometimes people have a lot of bony, extra bone in their mouth. On the mandible, if it's on the inside, it's called mandibular tori. If it's on the maxilla, on the palate, it's called torus. It's like one single lump of bone. Very, very difficult to take x-rays when there's big tori and torus in the mouth. They can also have a very narrow palate. They can have a very shallow palate. They can have a very strong gag reflex. So there are lots of other considerations, but those are more just experiential. You're just going to have to experience them on patients. Dexter's not going to have any of those complications. So that's just going to come with patient experience. So tomorrow morning, bright and early, are you guys happy that you did this? Everyone's still happy. Everyone still wants to be a hygienist, right? Everyone wants to be a dental hygienist. So tomorrow morning, bright and early, I will see you at 8 o'clock. We're going to go over some physics.